طبعا بيشرفني ويسعدني جدا ان انا اعرف واقدم استاذي الاستاذ الدكتور احمد تاج الدين، استاذ القلب جامعه قناه السويس، في محاضره قيمه. وطبعا الاستاذ الدكتور احمد تاج رمز من رموز جامعه قناه السويس الجميله، ورمز علمي قوي جدا وله اسهامات في مصر وخارج مصر طبعا. واستاذ احمد تاج الدين بالاضافه ان هو استاذ في جامعه قناه السويس، فهو نائب رئيس جمعيه او رابطه الاسمه، وهي بصراحه رابطه قويه جدا وعامله نشاط علمي قوي جدا على الفتره اللي فاتت دي. اضافه طبعا هو استاذي، وكان ليا شرف ان الاستاذ الدكتور احمد تاج الدين عضو في لجنه الاشراف الخاصه بيا في رساله الدكتوراه. فانا بيسعدني جدا وبيشرفني ان انا اقدم استاذي الفاضل، وهيكلمنا النهارده ان شاء الله على النيو ليبيد جايد لاينز. اتفضل يا بيه.
شكرا جزيلا دكتور طارق سالم، ويعني بشكر حضرتك للمقدمه الجميله دي، واحب اشير ان انا اللي بفخر ان يعني كنت مشرف على رسالتك للدكتوراه، وحضرتك نموذج يعني طبيب القلب واستشاري القلب المجتهد، يعني الذي لا يلو جهدا انه ياخد الكثير من الزمالات ويعني الخبره الاكلينيكيه والانترفنشن، وربنا يوفقك ان شاء الله.
شكرا
ان شاء الله. My talk today about management of dyslipidemia focus on 2019 ESC guidelines. طبعا I'd like to thank Professor Muhammad Awad for his initiative in inviting me for the Delta Diabetes Association meeting in cooperation with SHIDA 2020. So let's start first with this slogan: treat often, comfort, cure sometimes, comfort always, and harm nothing. If you see this illustration, it looks like a scorpion, and if you have a close focus on this scorpions, we will find that this is the leading causes of death worldwide, as you can see here very clearly. And on the top of the causes of mortality worldwide is cardiovascular disease. So this is my agenda today. Why dyslipidemia is dangerous? Is dyslipidemia controlled with treatment? What are the benefits of statins? What are the indications of PCSK9 inhibitors? And what about the ECC and ESC guidelines for management of dyslipidemia? So let's start first with why dyslipidemia is dangerous. As you see here, dyslipidemia is one of the important risk factors, major risk factors for cardiovascular, atherosclerotic cardiovascular disease and risk factors. Dyslipidemia usually never come alone. It usually come with hypertension and diabetes, and this triple jeopardy makes dyslipidemia more aggressive and make the risk of other diseases like hypertension or diabetes more vulnerable for progression of atherosclerotic cardiovascular disease. Why dyslipidemia is dangerous? Elevated LDL account for about 50% of MI risk and 25 to 30% of ischemic stroke. Cardiovascular disease cause about 18 million deaths per year according to WHO data at 2016. If you see this illustration with more total cholesterol going up, more cardiovascular disease risk is going up as well. So there is a close linear relationship between cardiovascular disease risk and total cholesterol level, and this is according to Framingham trial, one of the ever largest trials according to time and participants worldwide. And if we see here, this is how LDL is proportionally related to risk of coronary artery disease. So the more LDL you have, the more possibility of cardiovascular and coronary artery disease risk occurrence for this patient. For every 30 milligram per deciliter increase in LDL cholesterol, the relative risk of coronary artery disease increased by about 30%. So the number is very high. Elevated LDL or total cholesterol increase the risk of coronary artery disease independent of other risk factors. So even in absence of hypertension, in absence of diabetes, presence of LDL, elevated LDL is associated with great risk for coronary artery disease. This illustration is very important, and it tells you that if someone called you or asked for your recommendation regarding what to do, if he has one of his colleagues or himself with LDL, for example, 140, what should I do? You have to ask so many questions and do clinical evaluation and even laboratory evaluation, because for 140 milligram, and I say this as an example, 140 milligram of LDL, some patients are at low risk, others at intermediate risk, others at high risk, and others at very high risk for the same number. So don't judge the number, judge the patient. So from this diagram there, 140 milligram with no diabetes and no cardiovascular disease, the risk is not that much as compared with 140 milligram in presence of diabetes, for example, or in presence of coronary artery disease, or in presence of both. The risk is duplicate, and it reaches from less than 10% if no other diseases, up to 40%, and maybe more than that if the patient have both illnesses, coronary artery disease and diabetes. So we learn from this diagram, don't judge numbers, judge patients. That's very important in assessment of patients with dyslipidemia. This is how dyslipidemia could kill. Atherosclerosis, especially the progressive form of atherosclerosis, which lead to coronary artery disease, heart failure, peripheral arterial disease, retinopathy, and stroke, renal impairment. Actually, so all those jeopardies associated with dyslipidemia are related to aggressive atherosclerosis. If you are interested in numbers, each 40 seconds, someone dies from cardiovascular disease worldwide. And every 4 minutes, someone dies from stroke. And as I said before, in 2016, 18 million of patients died because of cardiovascular disease. What about the control of dyslipidemia? Worldwide, in patients who are taking even statins, control of dyslipidemia is not that much. And as you can see in this paper published in 2016, there is a remnant or there is a remaining patients who are not controlled despite taking statins, maybe because they are not taking them appropriately, or they're not taking the appropriate dose because of inertia of physician or inertia of the patient. They skip doses. The competence of patients in taking their medications at time, so the control rate is less than 30%. So it's about 21-22%. This is worldwide. What about Egypt? In Egypt, the control is about 34% at the maximum, even in patients taking medical treatment in the form of statins, of course. So what are the benefits of statins? Classically speaking, statins reduce LDL. So they reduce the risk of coronary artery disease, the risk of MI and cerebrovascular stroke. However, there is what's called the pleiotropic effects of statins, which together with reduction of LDL, which is very important, they represent the mechanisms how statins reduce the cardiovascular risk. So we have high intensity statins which lower LDL by more than 50%, moderate intensity statins which lower LDL by 35 to 50%. And as you see from this illustration, this is the pleiotropic effects of statins. And as you can see here, they have anti-inflammatory properties. They have effect on collagen. They have effect on reduction of inflammatory markers like macrophages, immunomodulation, and inflammatory markers, reduction of endothelin, improvement of endothelial function, improvement in nitric oxide availability, decreased platelet activation. So clearly speaking, the pleiotropic effects of statins play around the prothrombotic state. It reduces the prothrombotic state of the body. And as you see here, we have many types and many forms of statins. And you can clearly see that the high intensity statins are rosuvastatin 20 to 40 milligram or atorvastatin from 40 to 80 milligram, while all the rest represents either moderate intensity or low intensity statins. There is an old new concept of cholesterol lowering therapy, because with some combinations you might have important reduction of LDL, more than 50%, even more than 60%, like high intensity statins with ezetimibe. So you can reach more than 60% reduction of LDL, which is a very good target. Still, in some patients, you have to reduce the LDL to the minimum of about 40 milligram per deciliter, and we'll reach that in the next few minutes. Still, you can use intermediate intensity and moderate intensity with ezetimibe, and the result will be more reduction of LDL. So what are the indications of PCSK9 inhibitors? Those are the patients who are eligible for PCSK9 inhibitors. Patients with acute coronary syndrome in combination with a statin or statin plus other lipid lowering therapies in patients unable to reach LDL goals with the maximum dose of statin. So in a patient who has acute coronary syndrome, immediately after admission up to 1 year, if you can't reach the desired level of LDL, which is in some patients less than 55 milligram per deciliter, and in other high risky or extremely risky patients should be less than 40 milligram per deciliter, you can add on PCSK9 inhibitors to statins or statin and ezetimibe. So this is number one patient. Number two patients with heterozygous familial dyslipidemia. So patients with familial hypercholesterolemia, heterozygous form, again in combination with the statin or statin and ezetimibe. If you are reaching the goal of LDL, you can add on PCSK9 inhibitors. And finally, patients who are statin intolerant, alone or in combination with other lipid lowering therapy in patients who are statin intolerant or statins are contraindicated. So this is the resume of uses of PCSK9 inhibitors in patients with dyslipidemia. Familial dyslipidemia has many forms, and this is outside our talk. However, we can have type 1, type 2A, 2B, type 3, and type 4, and type 5 with different LDL and triglycerides elevations. So if you are dealing with familial dyslipidemia, you have to know all types and subtypes of familial hypercholesterolemia. So this is the recommendations for detection and treatment of patients with heterozygous familial hypercholesterolemia according to the European Society of Cardiology Guidelines 2019. So in children with families, descendants of families with familial hypercholesterolemia, you have to diagnose familial hypercholesterolemia if LDL level more than 160 if they are children. If they are adults, so it's more than 190 milligram per deciliter. of course, the numbers will not be as low as this. If it is homozygous familial hypercholesterolemia, LDL level might reach more than 400 milligram per deciliter. And this is something catastrophic. And those patients with homozygous familial hypercholesterolemia might pass away at age of 20s or 30s if they are lucky enough because of repeated coronary artery disease and cerebral strokes. So they might pass away yearly if not properly treated. In patients with heterozygous familial hypercholesterolemia, you might find a bit smaller numbers than 400 or 500, like 300, like 250 or so. However, the diagnosis of heterozygous familial hypercholesterolemia, LDL more than 160 in children, LDL more than 190 in absence, of course, of diabetes or established atherosclerotic cardiovascular disease. So this is the appropriate management of familial hypercholesterolemia. All subjects and their families should undergo health education about the diet, about exercise, about the treatment, about the cardiovascular risk. They should know that it's a fatal condition. It's important to quit smoking and never to speak about that being, I can have just small cigarettes or no. It's contraindicated to have to smoke actually on those patients and even in all patients with suspected cardiovascular disease. Dietitian should have a rule. Regular physical exercise is important. Assessment of cardiovascular status is important, and assessment of treatment, because patients with homozygous familial hypercholesterolemia, they should have lipoprotein plasmapheresis, while in patients with heterozygous, they could start statin therapy or PCSK9 inhibitors from above age of 8. Statins is indicated, and there are running trials now on pediatric familial hypercholesterolemia with PCSK9 inhibitors. What about the ACC, American Heart Association guidelines for dyslipidemia? We have old guidelines, 2013, and we have new guidelines, 2018. However, I see that American College of Cardiology guidelines 2013 are the most simplest, straightforward, and easiest way to tailor therapy and choose who should take medications or statins in patients with dyslipidemia. You have 4 categories of patients. We have patients with established atherosclerotic cardiovascular disease. So those patients should have strong or high intensity statins, especially if they are less than 75 years old of age. If they are more than 75, you can start with moderate intensity statins regardless of LDL level, except if LDL is less than 40, which we never see actually in patients with established atherosclerotic cardiovascular disease. So this is category number 1. Category number 2, patients without any other risk factors or diseases, but their LDL is 190. If they are adult, if they are young, so it's 160, more than 160 milligram per deciliter. So again, they should have high intensity statins. Number 3, patients with diabetes mellitus, especially if they are above age of 40 and having their LDL less than 190. They should start high intensity statins. The category number 4 are patients who didn't lie on those previous 3 categories. However, they have high cardiovascular risk score. Could be smokers, could be hypertensive, could be have family history of sudden cardiac death or family history of premature coronary artery disease, or smokers, or obese, this metabolic syndrome. So there is a score which you can, with it, judge whether the patient should have or not statins. I think this is one of the simplest, actually, and straightforward indications for statin therapy. This complex diagram we see now, this is an illustration of 2013 18 guidelines of American College of Cardiology for primary prevention and for secondary prevention of patients with coronary artery disease. Is not that much different from 2013, except for two issues. Number one, PCSK9 inhibitors. They should be used if you cannot reach the target LDL using the maximum tolerated dose of statins or statin and ezetimibe. Number two, ezetimibe comes before PCSK9 inhibitors in conjugation with high intensity statins to reach LDL goal. So this is roughly the changes in the guidelines from 2013 to 2019. What about secondary prevention? It's the same. In some patients, you have to reach less than 70 milligram per deciliter LDL, others less than 55 milligram per deciliter of LDL. Again, you will use statins as high-intensity statins. If not working, high-intensity statins with ezetimibe. If not working, you can add PCSK9 inhibitors. What about the ESC guidelines of dyslipidemia? And this was published as 2019. This is what was in 2016 at your right-hand side, and your left-hand side is 2019 changes. Lipid analysis is important. Pharmacological therapy is important. Goal is important. And I'll just skip some slides to reach this important one, because they have classified patients into very high-risk patients, as you see here, patients with established atherosclerotic cardiovascular disease, documented atherosclerotic cardiovascular disease having PCI or CABG or stroke. They are the very high-risk patients. Diabetes mellitus with target organ damage and duration more than 20 years. Severe impairment of kidney disease. Risk score more than 10%. Or familial hypercholesterolemia. So those are the very high risk. We have high risk, we have moderate risk, and we have low risk as well in the classification of patients who have cardiovascular risk score. This slide summarizes how to intervene and how to intervene with lifestyle modifications only or lifestyle modification plus statins according to the level of LDL. As I said before, some patients warranting reduction more than 55 milligram per deciliter, others less than 70 milligram per deciliter, others 100, and others 116 milligram per deciliter. Risk stratification is important, as I said, and patients with high risk and very high risk should be classified and intervene very early with lifestyle modification and medical treatment. This is the goal. Some patients, you need to have the goal of less than 55 milligram per deciliter, especially if you are looking for secondary prevention. In primary prevention, for patients at very high risk, you should reduce the goal to 55 milligram per deciliter. In primary prevention for individuals with family history, with familial hypercholesterolemia, you should have LDL less than 55 milligram per deciliter. In some patients, you need LDL to be less than 40 milligram per deciliter, especially if they have atherosclerotic cardiovascular disease and they have second vascular event within 2 years. And we have many patients with this category actually. In patients with high risk LDL reduction, more than 50%, less than 70 milligram is very important. So it's important to stop smoking, to have healthy diet, to do some sort of walking 30 minutes or even up to 60 minutes a day for 5 days a week, blood pressure less than 140/90, and reduction of LDL as appropriate, less than 40 in some patients, less than 55 in secondary prevention, and less than 70 milligram per deciliter in primary prevention and in other patients. How to reduce? You can use moderate intensity if you are seeking 30% reduction. You can use high intensity statin if you are seeking 50% reduction. High statins plus ezetimibe if you are seeking 60% reduction. PCSK9 inhibitor alone will reduce the LDL by 60% and in combination up to 80% reduction. These are the resume of the ESC guidelines. As you see here, start with lifestyle modifications, then with a statin, then high-intensity statin, then you can use high-intensity statin with ezetimibe, and then if not controlled, you can add PCSK9 inhibitor. So what about in diabetes mellitus? It's the same. So you deal with diabetes as a coronary artery disease risk equivalent. Reduction of less than 55 milligram per deciliter or 70 milligram in patients at high risk not seeking secondary prevention is important for patients with diabetes mellitus. This was the guidelines of ESC in management of dyslipidemia. This is my take-home message. You have many drugs that help to reduce LDL. You choose which to use according to your level of reduction, from less than 30% up to reduction of 80% of baseline LDL. These are the indications of PCSK9 inhibitors, and these are the recommendations for the levels you reach with LDL. Some patients, especially with established atherosclerotic cardiovascular disease, and they have another atherosclerotic cardiovascular disease event within a year or so, so you need 40 milligram or less of LDL. Patients for secondary prevention, less than 55 milligram per deciliter, and patients with primary prevention, less than 70 milligram per deciliter. Thank you very much, and I wish you a knowledgeable session in the DDA. Thank you.
شكرا جزيلا استاذ الفاضل الاستاذ الدكتور احمد تاج الدين على المحاضره القيمه والمعلومات الجميله اللي فعلا اضافت. انا اتعلمت طبعا كتير جدا من حضرتك من المحاضره، بالاضافه للمعلومات القيمه والتست جايد لاين. يعني مشكورا حضرتك ذكرت ان في، وده يعني عدد او رقم الى حد ما هو مش عالي، ولكن يعني مبشر. 34% كنترولد على الستاتين في مصر، قياسا بالهايبرتنشن زي ما استاذنا الدكتور محسن ابراهيم في الدراسه اللي عملها كان 8% بس هم اللي كانوا كنترولد. فاحنا نامل ان شاء الله مع برضه زياده الوعي الطبي باذن الله ان نوصل لاعداد ونسب كبيره من المجتمع تكون كنترولد ان شاء الله على تريتمنت باذن الله. سؤال بس بسيط لحضرتك بالنسبه للهيتروزايجس فاميليال هايبركوليستروليميا والتريتمنت وبدايه الستاتين ثيرابي مع اليونج ايج، حضرتك هل بتبقى نفس الدوزس؟ بندي نفس الدوزس بتاعت الادلت ولا بنبدا بدوزس اقل؟
وده طبعا سؤال مهم جدا. مشكله الفاميليال هايبركوليستروليميا انها اندر دايجنوزد which is يعني very bad، لان ده بيأثر على ال future events of cardiovascular disease. So if you have a suspected patient with familial hypercholesterolemia, you have to do lipid panel, and if it is high, you have to do for all family members, males and females. Then if he is a child less than the adolescent age of 16 to 18 years old, you can start above age of 8. Some references go for 7 years. However, most of references from 8 years up to 10 years, you can start statins. Usually, you will not go for high intensity statins. You can use rosuvastatin 10 milligram. It's in the approved indication for pediatric hypercholesterolemia or dyslipidemia, and you can use atorvastatin 20 milligram, and then you can escalate according to the liver enzymes, to the side effects, and to the level of desired LDL. At the moment, there is 2, I think, or 3 running trials for PCSK9 inhibitors, and the results, I think, will come up in 2021 or 22 about the use of PCSK9 in pediatrics. However, this is not yet there. So, yes, you have to diagnose early, lifestyle modification, diet, exercise, and medical treatment.
شكرا جزيلا. شكرا جزيلا. بنشكر طبعا استاذنا الدكتور احمد تاج الدين على المحاضره القيمه، وان شاء الله نكمل برنامج المؤتمر باذن الله.
شكرا جزيلا. شكرا دكتور.
شكرا باشمهندس.